So yeah, today I would like to talk about the brain assessment parameters uh, that we use to see how healthy the the brain is after a stroke. There are some important limitations we have in our clinical practice because we can kind of detect how the patient is improving from the peripheral point of view. So we can see if the patient is improving the range of motion of the hand, for example, but we have some limitations when we try to analyze these neuroplastic changes in the brain. So based on that, we did some research, and this presentation pretends to explain what we did and answer some of those questions. So right now, stroke is one of the most common causes of mortality and disability in our society. Uh, Evidence says that is the main cause of mortality and disability in adults uh, older than 50 years. And this has a big impact on the society because major part of these people is having secondary effects that affects the daily living activities. It's said that 100% of these patients requires at some point of the medical intervention rehabilitation. So this rehabilitation is always a challenging step on the treatment, right? So there are some advances that we did in the prevention and treatment of the acute stroke that allow us to reduce the prevalence and the mortality rate. But still, the absolute number of strokes are increasing year by year, and this is again affecting the society, right? So once I read a paper that says that the 70% of people that suffers from a stroke has some motor impairment because of the stroke. So you can imagine how difficult can be for rehabilitation services in the hospitals to treat such patients. Recovery is very common that is happening during the first 6 months after the stroke, what we call the subacute phase. So until some years ago, there were some publications that they defended the idea that you can recover only in the first 6 months. After these 6 months, you reach a plateau, and they said that this would not be possible anymore to improve. But in the recent years, we see that this was not totally true, and we can still see some functional improvement in the chronic phase. In the other side, as I mentioned before in the first minute of the presentation, we have some important limitations evaluating the brain state after the stroke when patient is in the rehabilitation service, right? So using recoveries for so many years, I had some doubts and I had some questions to answer as a clinician. I saw the amazing results we get with neurotechnology, with PCI, with recoveries, and I wanted to see deeper in the brain what was going on, because there are some famous scales that allow us to track very precisely the movements, the improvement in the movements and range of motions, I don't know, muscle balance, whatever. But when it comes to to detect the changes on the central nervous system, it's again a problem. When we treat a stroke patient in the rehabilitation service, we pretend that these functional improvements are coming from the brain, from the central nervous system. We are not treating the peripheral muscles, right? Because the muscle itself it's healthy. What is affected is the is the central nervous system, right? So we expect that our therapy is kind of affecting or improving the functionality of the central nervous system. So this current functional assessments are not able to detect these changes in the brain. These neurorehabilitation therapies should also track these adaptive changes in the brain and allow us to quantify these neuroplastic changes. So I remember this sentence from one of my professors in the university that once he said something that cannot be measured cannot be improved. So probably if we have more knowledge about how to analyze these brain changes, we can explain better why some patients are improving better than others, right? So, and this, now I will start talking about EEG, electroencephalography. So, because it's the technique that I use for analyzing these brain parameters. So, neurophysiological, this EEG give us neurophysiological information from the brain, and these EEG changes can be related to the clinical scales that we use in the clinical practice. So just a short explanation about advantages and disadvantages of EEG. So EEG is a very common technique for analyzing the brain responses. This technique allows us to record the brain electrical signals. It's a non-invasive method, so this means we don't care about such limitations or contraindications or secondary effects that one can have doing some kind of neurosurgery. So because this is non-invasive, so it's very straightforward. It's very easy to set up an EEG cap, as we said, we saw in today in the morning. Is a cheap technology compared to fMRI or other more expensive techniques, and it's very easy to transport the system. You can put an EEG device easily in your bag, right, and go anywhere to do the assessment or the therapy based on EEG. Give us a very good temporal resolution. This means since the electrical changes are generated on the brain until we record them and we analyze them, then there is a very short time. The temporal resolution is very good. And there is also another very good feature from this technology is that we have this international distribution system that allow us to reproduce again the same experiments, right? So you can see here in the right side of the slide this schema, this theorem. So this is the international distribution system where you can see different points with different letters and numbers. These coordinates, kind of, well, yeah, we can consider them coordinates, allow us to see specifically in which region we place the electrodes between one experiment and other, right? Of course, not everything is perfect, and we have some disadvantages on this technology. The spatial resolution is not as good as other invasive techniques. And of course, it's very difficult to interpret the EEG signals. If you need an extensive background on EEG to understand what's going on just by reading the EEG waves in the scope. So based on that, so many years ago, I figured out two major objectives in my research. One was to evaluate the clinical effects of the BCI therapy in stroke patients. I was totally amazed about the results we were looking in the recoveries gym, and I wanted to quantify them. And the second objective was to evaluate the different EEG biomarkers that can be used for the stroke diagnosis and prognosis of these patients. We did extensive research on that, and we did a lot of publications that you can find basically in Frontiers, and you can see exactly the detailed results. So this is a short summary of the main quantitative EEG parameters that we analyzed. Basically are these 5 parameters: the delta alpha ratio. We use this acronym DAR, the power ratio index, PRI, the brain symmetry index, BSI, and then we have the laterality coefficient for the alpha and beta band. Let's see, alpha and beta. So we analyzed these parameters in 2 different conditions. One was in resting state, and the other was during motor imagination. And additionally, these experiments were done in 2 types of populations. So we recruited some healthy participants to see the standard, or the, let's say, the normal or the physiological values of these parameters. And then we also recruited some stroke patients where we analyzed these same quantitative parameters, and also we analyzed the clinical effect of the BCI therapy. Okay. For example, when we see the laterality coefficient, we evaluated this parameter during the motor imagination. So this motor imagination was for the healthy and for the paralytic hand in the stroke patients. And that's why we sometimes use LCH to talk about the laterality coefficient during the healthy and motor imagery, or LCP for the laterality coefficient for paralytic and motor imagery. There are a lot of acronyms, but it's a bit complex, so I try to explain it in the simplest way using these acronyms and don't repeat many times the same long words. So for the first study that we did, we recruited 32 healthy participants and 34 stroke patients. The healthy participants were only doing resting state EEG during 8 minutes with eyes open. So they were just looking to the wall with eyes open, and they were just doing nothing. They were not moving, they were not doing any math or any calculations, and just looking the wall. And then we had these 34 stroke patients that they did exactly the same than the healthy participants, just seated in a comfortable chair, just looking to the wall during 8 minutes with the eyes open. And then we did a second paradigm of the experiment with these stroke patients with recoveries, right? So we involved them in a recoveries therapy, in a BCI therapy. So these patients were in the subacute and chronic phase. The major part of them were in chronic, and they had different types of stroke, and we categorized these stroke patients based on the stroke location, right? So Some of them had the stroke only affecting the cortical area. There were some others that affected the subcortical area only. And then there were other patients which the damage was more extensive and affected the cortical and subcortical areas. For the BCI protocol in the stroke patients, this symbol means stroke patients, they did one functional assessment, which what we call pre-1. Then we waited for 1 month, and then we did a pre-2 assessment. These two pre-assessment allowed us to see the baseline of the patient, if the patient had a stable baseline or if they were changing the baseline, so the functional status during this month without recoveries, without any intervention. And then just after the pre-2, they did 25 sessions of recoveries, BCI therapy, 2 times per week. And then just after the last BCI session, they did the post-1 assessment, where we repeated exactly the same assessments we did in pre-assessment. And then 1 month after we did the post-2. Again, I explained just very short how this BCI device works. So we have a patient with an EEG cap. This EEG cap was recording the EEG signals during the motor imagination. These EEG signals were sent to the computer through this biosignal amplifier. The computer was analyzing these EEG features in real time. And if the patient was doing properly the motor imagination process, then the computer was activating the virtual reality feedback, the visual avatar, and in parallel also the functional electrical stimulation on the patient's forearm. So when the patient was doing properly the motor imagination, he could see the avatar moving and also his hand rising. Okay, if the patient was not activating well the motor cortex, then this patient was just receiving no feedback, right? This is a brain plasticity loop, a motor learning. These are the scales that we use in the different assessments. For example, the primary outcome was the Fogel-Meyer assessment for the upper extremity, but we also use the lower extremity, and we only use the motor part of this scale. If you know a bit about this scale, you know that you have 2 sections. The first section from 0 to 66 points, which is the motor assessment, and then there is a second section, which is the joint pain and also sensibility and such things. So we only focus on the motor section. Then we have the box and block test, which assesses the grasp ability. The 9-hole peg test, which is also assessing the grasp, but this time between the index and the thumb, just picking one peg and moving to one hole, and we check the time that the patient needs to bring these 9 pegs and to move them. Then we also use the fan tremor rating scale to assess the tremor degree, the modified Ashworth scale to assess the spasticity, the Montreal cognitive assessment for the cognition, the 2-point discrimination test for sensibility. Then we did a self-rated questionnaire to evaluate the function and memory, and then the Barthel index for the activities of daily living. The first quantitative EEG parameter we analyzed was the brain symmetry index. The brain symmetry index is calculated using these 10 EEG channels. Okay, so basically what we try to evaluate is the symmetry. So how symmetric is the activity of the left versus the right hemisphere using this formula that was published so many years ago and was extensively used for another purposes. So we expected that the brain symmetry index was having low values, so values near to 0. But first of all, we analyzed this brain symmetry index with healthy subjects. We had very different persons on this population of the healthy subjects. So we tried to see if this brain symmetry index changes during the time, so in different age groups, and we saw that that is not that case. So the brain symmetry index is a stable value that doesn't changes with the years, with the time. So there was no significant difference between people in different age groups. And then we compare based on the sex. So we took the brain symmetry index values from males and from females, and we compare them. And we noticed that for first time, I think this was the first time that was published in the literature, that the brain symmetry index has a significant different value in males or females. And this observation can help us to interpret the brain symmetry index when it comes to real patients, right? So we know more about this index hope, which is the behavior of the brain, and also from this parameter. And we can have more information when we see a patient with a value of coming from a patient. Right? So when we try to compare these results with the rest of the patients. So we have in this box plot, we have 4 boxes. The first in the left side are the healthy population. So the same values we saw in the previous slide, right? So we're all together here. And then we split the stroke sample based on the stroke location, cortical, subcortical, and cortex plus subcortex. Unfortunately, the cortex group was really small. We only had 4 patients, but we had many in the other 2 groups. And we saw that there is a statistical difference, significant difference between subcortical and cortex plus subcortex versus healthy. So this parameter is significantly different when you have a stroke in the subcortex or affecting subcortex plus cortex when you compare it with a healthy. So this thing brings us to believe that maybe this parameter can be used for the diagnosis if you have high values of brain symmetry index. It's probably because you have some problem in your brain. Maybe you are having a stroke, or the data that you're analyzing is from a stroke patient, right? Because the healthy subjects have lower values than a stroke subjects. And this box plot that we had in our publication was pretty similar to another previous publication from Anastasi et al. In 2017. So when we look in the ACE open box plot distribution, is pretty similar to this box plot distribution, right? So they didn't have the cortex plus subcortex group. They only had healthy, blue box, cortical, green blocks, and subcortical, which was this yellow box, right? So these 3 boxes are pretty similar. The funny thing is that Anastasi et al. Had a very low sample size, around 10 or 15 patients. I don't remember exactly, but when we extend the sample size, when we prove this value in a bigger sample, the distribution of the boxes are pretty similar, which bring us to believe that maybe this brain symmetry index parameter has low variability. And this, when we talk about EEG, this is very important, the variability of the parameter between assessments. And we also found another interesting correlation. So looking only the data from patients, we saw that the brain symmetry index values are directly related with the Fugl-Meyer assessment of the upper extremity uh, parameters. So lower values of brain symmetry index are related with better functionality on the arm, the upper extremity, and this Spearman's correlation was significant. Sorry. We analyzed other QEEG parameters. For that, we use the band powers parameters. We know that based on the band power, we have 4 different bands. We use the 16 electrodes you see in blue color here. We have the delta band, which is between 1 and 4 hertz. The theta band, which is between the 4 and 8 hertz. The alpha between 8 and 12, and beta 13 to 30. And using the Wells method, we could calculate the delta alpha ratio and the power ratio index. Okay. So in the literature were also used these parameters with lower sample size and also other not only stroke populations, but we expected that the delta alpha ratio, DAR, and the power ratio index, PRI, had lower values. So because we saw in the literature that these lower values were related to better functionality. So we did several correlations between the DAR and the different scales, Bartel index, Funk tremor rating scale in the paretic hand, box and block test in the paretic hand, the Fugl-Meyer upper extremity motor functions, pain evaluation, and also the subjective function questionnaire that we use. And we saw that in one of each cases, the lower values of the delta alpha ratio were related to better performance on the daily living activities. Lower values on the delta alpha ratio were related also to lower tremor, better ability for the grasp function, and better functionality on the Fugl-Meyer. All these correlations were significant. Also, less pain and better functionality, subjective functionality. Then we saw similar results in the power ratio index. Again, the power ratio index was significantly correlated with the Bartel index, with the box and block test on the paretic hand, the Fugl-Meyer assessment of upper extremity, only the motor section, the pain and memory. So these two EEG parameters are giving us a significant correlation between the brain activity and the functionality that we can see externally on the patient. Okay, so this suggested us that these two parameters are a very good tool for assessment, evaluate the patient's functionality. Then we used another parameter, which was the laterality coefficient, was described by Kaiser et al. In 2012. And basically for that, we use the C3 and C4 electrode. This parameter is calculated during the motor imagination. So this is a paradigm description of recoverix. So each recoverix trial lasts for 8 seconds. So between the second 0 to 3.5 there is the preparation phase, and then after the patient receives the cue, where is the imaginated movement left or right, the patient starts doing the motor imagination, and then we have the active feedback phase in real time, right? So just looking the feedback phase when the patient is doing the motor imagination, is where we calculated the laterality coefficient. We only took the EEG between 3.5 to 8 seconds, and based on that we can calculate and draw these ERD ERS maps. These ERD ERS maps were already explained in several talks until now in this spring school. Just very quickly explanation. Basically, what these ERD ERS maps should be treated in horizontal from left to right. So if we just look the C3 and C4 plots in the upper side, we see here this label, right hand motor imagination. So this is what happens in the C3 and the C4 electrodes during the right hand imagination. So we know that when we try to activate the right hand movement, this is the activation is coming from the left hemisphere, so the contralateral hemisphere. So we saw here that the responsible brain area of the right hand movement is under the C3 electrode, and we saw these these hot colors, let's say red, green, orange colors. Okay, so this means activation of the left hemisphere. In parallel, we can see in the same moment that in the C4 we have less activation, less hot colors, we have cold colors instead, right? So we have blue, green colors, right? So because when the C3, so when the left hemisphere is activated, what we expect from the physiological point of view is that the ipsilateral hemisphere, so this means right hemisphere during right hand imagination, is silent, is not active. Okay, this is from the physiological point of view. This is what we expect, right? And this is also what we see in the real experiment, in the real life. Now, if we check the lower ERD-ERS plots during the left hand, we see that it's happening totally the opposite in the C3. So this means when we move the left hand, the ipsilateral hemisphere is not active. It's having blue colors, cold colors. And in the C4, we have red, orange, yellow colors, which means activation, right? So based on these ERD, ERS maps, we calculated the laterality coefficient for the healthy hand and also for the paretic hand in the alpha and in the beta band. But just to make it simpler to understand, I just explain here the results of the laterality coefficient of the healthy hand in the alpha band. Okay, if you want more specific results, I can share for sure the link to the publication. Is an open access publication, so you can really see there all the different correlations and all the analysis done in each one of these parameters in the paretic and also in the beta band. So we saw that the laterality coefficient of the healthy hand in the alpha band was a very good parameter, was very stable, and this was significantly correlated with different scales. We saw that high values of the laterality coefficient healthy hand in alpha band are related with high tremor. So values near to 0 are related with less tremor, and also values near to 0 are related with better grasp functionality assessed by the box and block test. Again, laterality coefficient values near to 0 are related with better functionality in the upper extremities. And to me, this is one of the most important findings in this research. It's the first time that we see that one quantitative EEG parameter is significantly correlated with a lower extremity assessment. Okay, so the LC parameters near to zero are correlated with better lower extremity functionality assessed by with the full Meyer assessment for lower extremity. So here you can see the correlation coefficients in each one of these four comparisons, and also the significance, the p-values. Okay. Yeah, in the previous years, many people were asking about the motor imagery as accuracy as a quantitative EEG parameter. Once again, today we talk about this publication with 51 patients, was mentioned in the previous talks. This time we had 51 stroke patients recruited on this study. The major part were in chronic phase, but we had also 12% in subacute phase. Then we also categorized them based on the impairment degree. So we did this Fugel-Meyer upper extremity assessment in the pre assessment and pre-1 assessment. And we could, based on these Fugel-Meyer values, we could categorize the sample in severe, moderate, or mild. So the major part were in the severe group. We had 18% in the moderate and 13% in the mild group. Again, the protocol was exactly the same than in the other study. We did one pre-assessment, 1 month after second pre-assessment. Then we had 25 sessions of recoveries, 2 times per week. And then we had the post-1 assessment just after the last PCI session, and post-2 assessment 1 month after. We also had the post-3 assessment 6 months after the therapy. Yeah. So when this figure is it's very important. It's one of the main findings of this research. The primary measure this time was the Fugel-Meyer upper extremity, as in the other study. So if we look the left box and block, the left box plot, we have 3 boxes, right? So the first box is the comparison between pre and post. So we did the average between pre-1 and pre-2, and we call it pre. So we saw that the comparison was significant. This is what means the small star, black star in the top. So this means that the patients improve significantly in the Fugel-Meyer upper extremity score. The average improvement was almost 5 points, was above the minimal clinically important difference. Then the second box was the comparison between post-1 and post-2. So we compared the results of the Fugel-Meyer just after the BCI treatment with 1 month after the treatment. And there was no significant difference. This means that all the gained functionality after the BCI treatment, the recovery treatment, was maintained at least 1 month after, because the comparison between post-1 and post-2 was not significant, or 0. And then we did the same, the comparison between post-1 and post-3. So we compared the results just after the therapy with 6 months after the therapy. And we saw that there was no significant difference either. So this means that the functionality gained, achieved after the BCI therapy was maintained at least 6 months after the therapy. This is very uncommon when you see publications on this field, because major part of treatments, when you stop the treatment, after some months, the functionality decrease again. This is the case if you only treat with functional electrical stimulation, just electricity, just muscle activation without anything else. When you stop the treatment, maybe you see some improvement, but when you do a reassessment some months after that, you see that this functionality that you gained during this treatment was lost. So this is not the case. After 6 months of the recovery treatment, the patients had similar functional results. The values on the Fugel-Meyer were still the same. So when we see now the box plot in the right side, the box plot B, so we have here 3 boxes. The first box in the left side, so this box plot tries to correlate or to compare the difference, so the delta in the Fugel-Meyer upper extremity based on the motor imagination accuracy. So the first box is exactly the same as we have in the other. So the improvement was still the same. And then we split the sample in 2 groups. Those patients who had a motor imagery accuracy above 80% and those patients that had the motor imagery below 80%. And we could see that patients who had higher motor imagination accuracy, so above 80%, they improved almost 7 points in the Fugel-Meyer, compared to the other group, which was below the 80%, had 3 points. So this it's very important because one of the main parameters or the main factors that you can see during the BCI therapy is how is the motor imagination accuracy, right? If the motor imagination accuracy is high, you can expect that this patient is improving more, right? Can somehow predict the evolution or of the patient from the functional state point of view. We also had very nice improvements in the modified Ashworth scale, the spasticity. So the spasticity was reduced significantly in the wrist and also in the fingers. The 9-hole peg test in the healthy hand was also increased. Was a very good improvement we had also in the healthy side. We see here this significant improvement in the Fugel-Meyer upper extremity. And this table shows the middle term and long term effects. So there was no significant change in each one of these different scales. So this means that the results were lasting 1 month or even 6 months after the treatment, right? So again, when we compare based on the severity group, we see that all patients improve significantly, especially the improvement is higher in the moderate group, but in all groups we have this significant improvement. So this is very good because BCI therapy can be applied to many different type of patients. Doesn't matter exactly which is the baseline status, right? So yeah, I know that I don't have too much time, but so when we see the summary of conclusions about the quantitative EEG parameters, we can see that the EEG biomarkers can be a useful tool for stroke diagnosis and prognosis. Males have higher values of the brain symmetry index than females. This is the first time that this is published. The healthy participants had significantly lower brain symmetry index values than stroke patients. In stroke patients, lower values of brain symmetry index correlate with better functionality in the upper extremities, assessed by with the Fugel-Meyer assessment. And also in stroke patients, different parameters related with pulse powers are correlated with activities of daily living. When we see specifically the delta alpha ratio is also related with the level of tremor in the paralytic hand. And when we see the laterality coefficient values for the healthy hand that are close to 0, correlated with better grasping function, lower tremor, and better motor functionality of the affected upper and lower extremity. As a general conclusion, we can say that the selection of the functional assessments is one of the most important clinical decisions during when you are designing a research protocol or when you are assessing a patient in the clinical practice. It's very important. It's a step. You should know exactly the measure that you want to use and see if really can 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 help on the evaluation, on the assessment of this case, right? The conventional scales used to assess the functional state of the patients have correlations with the central nervous system responses. And the BCI technology allows the clinicians to have to know better uh, the patient state, because you can know exactly how is going on the performance during the therapy using this motor imagery accuracy, and also you can see how these EEG parameters are changing during the therapy, and because they are related with functional assessments. Um, this PCI technology also allows to the patient to follow in detail the brain changes to get information about the patient in a very easy and fast way, and allow us to the patients, to have a very accurate diagnosis. The current and valid scientific techniques and methods in rehabilitation should be combined with the new paradigm, which is the technology, in order to achieve better results. And I think really that it's now the time that we learn as a clinician these new methods, provide scientific evidence to what we are doing, to this research work we are doing, and introduce these methods to the clinical practice, because this is a very big advantage for our patients. Okay, I'm on time. So thank you very much for listening. I will be happy to answer your questions.
Thank you very much, Mark, for the nice presentation. Rastov wants to know, maybe that's from the previous study still, but you can also answer maybe. What do you expect if you study twins with neurorehabilitation? So it's just very unlikely that both have a stroke, but any clue about twin studies?
Sorry, I can't understand the question.
So twins, brothers and sister born at the same time. So what do you expect if you study them with motor imagery, brain-computer interfaces?
I expect assuming that they are not having any damage, right? They didn't have any stroke or anything. So what I expect, for sure, the cortical activation patterns are independent. So they each person have their own cortical activation patterns. So I would expect that they have different quantitative EEG parameters in the baseline. And if they have a stroke and we have to treat them, for sure, this depends on the stroke location and the degree of damage they had. But I don't expect that the parameters are similar or identical.
Osam wants to know, does this significant PSI difference between male and female lead to an enhanced risk of stroke?
No. Just the brain symmetry index just explain us that the behavior of this parameter in two different brains, but this doesn't mean that if you have that the males have more risk to have a stroke than females. This is because other factors like genetic reasons, or also toxic habits or such other things.
And Andrew is saying excellent session. And somebody wants to know, is the Vogel-Meyer assessment the most widely used test in the BCI literature, or do you think there's another better test available?
No. For assessing the upper extremity, I would say that Vogel-Meyer is the best tool you can have. Coming to the lower extremity, then maybe there is more discussion about that, because the functionality of the lower extremity is mainly assessed by gait scales. But then, of course, you have troubles if your patient population can't walk at all. So for upper extremity, yes, Vogel-Meyer upper extremity is the gold standard. I recommend you to use it and to learn exactly how to use it. And for lower extremity, maybe I would use some gait-based assessment, like 10 meters walking test.
So the Vogelmeier assessment is a good one, but it doesn't show full improvements all the time. So I gave a couple of examples where the Vogelmeier improvement was, for example, 5 points, which is good, but not really great. And if you look at the 9-hole pack test, then it's a tremendous improvement. So you need also other tests to fully pinpoint what is actually getting better. By just hearing Vogelmeier 5 points, you don't fully understand it. If I know if a 9-hole pack test is 100% better, I know hand motoric functions, fine motoric functions are much better. And then there's also box and block test for whole hand movements and arm movements. You don't get it from the Vogelmeier assessment. And on the other hand side, if you have severely impaired patients, then these patients very often cannot do the 9-hole pack test or box and block test because the hand looks basically like that. A lot of spasticity, no movement at all. And then the Vogelmeier score allows you to at least find and identify some improvements because you cannot use the 9-hole pack or box and block test. So a combination of different tests is definitely very useful.
Yep.
Let's see. I think we have everything. Thank you very much,
Nice.
Mark, for the nice presentation.